next talk will be Dr. HEMANTH MURTHY. He will be talking about managing myopic tractional maculopathy.
Yeah. Okay. Yeah, I would be speaking to you on vitrectomy for myopic tractional maculopathy. So we used to call it commonly myopic foveoschisis, or now we know that as myopic tractional foveoschisis, commonly seen in pathological myopia in about 8 to 34% patients. There are various factors. One of it is the vitreous traction. Then there is the tangential traction from the premacular membranes, and because there is a staphyloма, there is an inverse traction from the posterior staphyloma. So these opposing forces causes the foveoschisis. Though the exact cause is not known, there is a relative stiffness in the inner retina as compared to the outer retina. Hence, there is foveoschisis in the staphyloma area. So some of the causes are that the ILM tends to be more rigid and along with the inner blood vessels, along with a very frequent association of incomplete PVD causes foveoschisis. The natural course is variable. We know that a lot of them have stable vision for long period of time. So some of them are asymptomatic. And when they develop metamorphopsia or blurring of vision, we think about doing surgery. And sometimes when it progresses to a foveal detachment, then one needs to do a surgery as it frequently leads on to a macular hole and a retinal detachment. Some of the foveoschisis that we commonly see are very much similar that you would have encountered. There have been 4 stages described on OCT, and once there is a development of the foveal detachment, that's the stage wherein you need to operate on foveoschisis, as waiting for it will invariably lead on to developing macular hole detachment. There are 2 ways of tackling this. There's one in which we do ILM peel and one without. I know that in the news, in the recent newsletter of the VRSI, Barbara Parolini, she said, I don't peel ILM in foveoschisis. Actually, I have not been doing peeling of ILM, so I just want to share some of the cases that I've done. Kwok has also shown that vitrectomy alone without ILM peeling improves outcomes in these patients. So this is a patient who came to me in September 2014, a vision of 624. I observed the patient again in March 2015. Vision continued to be stable, but then when she came in November 2015, there was a small foveal detachment, as you would see in the lower panel. There is a small foveal detachment. At this stage I said, and there is a drop of vision, so I said you need to do surgery. So she underwent surgery, and you can see that I've removed the cannula to give me the length. And on surgery, after staling with with triamcinolone, I just peeled the posterior hyaloid. So this is one thing that we need to repeatedly see and stain and use triamcinolone liberally and try to remove the posterior hyaloid. And then I continued to peel the membranes as they went into the periphery, and we could see that she could get back 618 vision and the macula settled very normally. The OCT looks good. There's another patient, a 32-year-old gentleman who came with blurring of vision of 660, and this is the OCT that looks with an inner wall break with a foveoschisis. And in this too, I just did the hyaloid removal. So there's always a very frequent association. I think majority of them do have vitreous which is adherent at that place, and that's what causes the traction. So releasing this traction actually releases the foveoschisis. So one needs to continue up to the periphery, try to make it as relaxed as possible, because this is very rigid. So having done this, this is the post-op OCT, and patient improved to 618. So this is the post-op OCT of the patient. There is another patient who came with a macular hole detachment. So in this, however, after the vitrectomy, we do peel the ILM. So this is, I'm just peeling the hyaloid now in the posterior pole. So most of them do have this vitreous which you need to identify. So I think the key to success in myopic foveoschisis is managing the vitreous rather than anything else. And then you ensure that you remove all the posterior hyaloid. You need to repeatedly stain and identify. This is a very common appearance. I think all of us who operate on myopes, we feel that this is the most common thing that you would see in most of these patients. And after you peel the ILM, then once you're able to do this, then we peel the ILM. Because this is a macular hole detachment, I always peel whenever there is a macular hole. Just on foveoschisis, I don't peel the ILM. So once this thing is peeled, this is the post-op OCT which shows an closed hole and attached retina. Here's another patient who had a pre-op vision of 660. Following, patient had previously undergone scleral buckling for retinal detachment, came with foveoschisis and symptomatic, had a foveal detachment also, as you could see. So to prevent any further loss of vision, and you can see the vitreous traction, that is what is commonly observed in most of the OCTs. And in this too, we stain with triamcinolone and peel the posterior hyaloid that is there. So most of them just required this. It tends to come out as a single membrane, though it breaks at times, but one could remove all this. So this is essentially what I would suggest in most of these patients. And the day 3, you can see that it is settling down. And at 2-month follow-up, though the vision remained same, you can see that there is no foveoschisis now. So some of the common problems we find is that the instruments required are longer. So you need to be more vertical. Now one should understand that when you do 25 gauge, there is a stiffening sleeve. So what do you do to avoid it is, I use a 1-port 23 gauge valve cannula, and I use the 25 instrument itself because that passes through 23 gauge port, the active port. So that gives me the inner increased length. Sometimes when even you read more than that, you remove the cannula. The other thing is, even though the patient is pseudophakic, I put the port at 4 millimeter so that, and more towards the horizontal meridian so that I get an closer, the access becomes much easier. So these are certain tips that you can do to get an access. You also have extendable cannula, and some of the times I use a 23 gauge 1.5 inch needle to give me the lift of the membrane. Though the contrast is poor, you can manage to stain the ILM with brilliant blue, so that's a very good tool. So in conclusion, we see that managing foveoschisis is a lot simpler. One need not worry too much about the ILM. I've seen in most of my patients, I've never peeled an ILM, and it does work. Only in macular holes, you need to peel the ILM. I think that's the key to it. Thank you very much.
Thank you very much, Dr. Hemanth. This always a debatable topic. We'll have a few questions at the